Welcome, everyone. We're happy to have you join us for this next CME presentation. We had a very successful first presentation several weeks ago, and we're very pleased to be able to welcome you to our next in our growing series of webinars. Welcome, whether it be morning, afternoon, or evening, wherever you are in the world, we welcome you and thank you for attending. This will be a CME webinar, meaning that you will be able to collect free continuing medical education credits and the instructions for obtaining these will be at the very end of the presentation. So our topic today is treating wound care patients and training residents on the front line during COVID-19. We thought this would be a particularly relevant conversation to have, since it's placed a burden on those of us who have trained residents and have large training programs in our hospitals. So therefore, we welcome Dr. Ronald Guberman, who practices in Brooklyn, New York. He's the residency director at Wyckoff Heights Medical Center in Brooklyn and the co-director of the Podiatry department. They have a very large training program with 20 podiatry residents. This COVID-19 has placed a particular burden on their training program, of course. Dr. Guberman is a co-founder of the Hospital Wound Center, which was started years ago. He's board certified in foot surgery by the American Board of Foot and Ankle Surgery. He's also in private practice in New York City and Westchester County, New York. So with that, let me welcome Dr. Guberman, who will give us a very important and insightful lecture. So Dr. Guberman, it's all yours. And I'll be back later for questions. But before I sign off, let me remind everybody that there is a question panel on the right side of your screens. And we encourage you to put your questions in the question panel so that we'll have a vibrant question and answer period at the end of the presentation. So again, welcome all, and Dr. Guberman, we're happy now to turn over the show to you. Dr. Guberman.
Thank you very much, Dr. Freiberg. Thank you for that introduction, and it's really a pleasure to be here. I greatly appreciate people taking time to join this webinar, and it's a topic that I'm very interested in, as it's something that I do all the time, and it's something that I am devoted to as far as training residents and treating wound patients. So what I want to talk to you about is first, this is my disclosure statement. And here are our learning objectives. What we want to do in this particular webinar is explain processes and modifications we've undertaken to ensure the safe and effective and appropriate treatment of our wound patients. All of us are experiencing this crisis, and in the wound center in particular, in the hospital, there are certain challenges that we've undergone. We're in Brooklyn, which is, considered by many to be the epicenter of this crisis, and we've needed to really respond quickly. We've learned a lot of lessons, and we want to share those with you about how to better treat our patients and teach our residents, and we want to review that with you. We want to talk about a future where we can use these processes. This is a learning experience for all of us, and hopefully we can gain some benefit from our experience during this crisis on how these processes can be better and better serve our patients and keep us safe in the future. So I highlight the New York State Department of Health for a couple of reasons. One, they're a tremendous resource. They've gone through the trouble, and they go through the trouble, which I guess is part of what they need to do, of coordinating a lot of information from various agencies and providing information to healthcare providers as to upcoming questions, problems, and guidelines. There are certain mandates, and there are also policies that, and also suggestions that need to be followed. And then there are also hospital guidelines that take from this and other information to make for hospital and local policy. So we need to be aware of all of these things. There is lots of information in the last couple of weeks. Things that have come out have been on, new testing available. There's also warning about if you're going to get tested, for example, for the antibody itself, be careful to make sure that you're getting a test that's FDA approved. There are many tests out there that are not FDA approved. There are approximately 65 or so, probably more as every day as we speak, approved tests just for the molecular testing, the PCR testing for having the condition itself. And these platforms are approved to make sure that there's wide availability. So that was noted, and many of these are available both in hospitals and other facilities, pharmacies, drive-thrus, etc. There was also a great deal of information recently about the pediatric condition that causes an inflammatory condition that's different, PMIS, that's different from how it affects the general population. And there's specific recommended testing for this condition for pediatrics. So this is very important information. At Wyckoff itself, as I said, as an epicenter, US is sort of the central area, New York State, and then Brooklyn, Queens, and the Bronx are noted most recently to be the most highly affected areas. Wyckoff Heights Medical Center, where I've been since 1988, January of 1988, is an active urban New York City teaching community hospital. It's a very busy facility. The patients there have a very high rate of COVID-sensitive comorbidities. I guess you could say in general, they have a very high rate of comorbidities. So certainly this became an issue very early on. And as we know, early on in this condition, there was a lot of unanswered questions. There was a lot of confusion as to what type of procedures we should undertake as far as masks, as far as PPE, et cetera, which has been fortunately ongoing and clearing up. The catchment area itself around Wyckoff was highly affected, and immediately there became a lot of patients that presented both the emergency room and were admitted to the hospital. This presented us with many challenges, as you can imagine, and very much ongoing communication and concern and need for educating ourselves and others around us as to what proper procedure was. I have to say proudly that Wyckoff has been recognized by both the state and the city, specifically recognized Wyckoff for their care of patients with COVID. So some of the hospital policies and procedures, which I want to highlight, are, being where we're located and being the severity of this condition, there's continuous communication between senior members of administration, between nursing, podiatry, and all the medical and surgical departments, all the department hospitals, through email, texting, and policy statements, which has been very important because things change sometimes on an hourly basis or a daily basis. The hospital itself was charged with focusing on inpatient COVID treatment as a primary necessity. And the triage areas were even put into the main areas of the hospital, main entry areas. Significant portion of the hospital converted to treat just COVID, and areas that didn't even have beds were placed and respirators were gotten fairly early in order to treat these patients. All the departments were affected, and many were deployed to assist either directly or indirectly. We had a cancellation early on of elective surgery, which was mandated, and currently we only are doing tier 3A and 3B on the elective surgery acuity scale, which we must follow, and we have a application for waiver in process, which we're hoping will be approved very, very shortly for tier 1 and tier 2 cases. So specific to podiatry, what modifications did we need to undertake that were different or in accordance with the hospital? Well, some of our residents were deployed for direct COVID treatment. We had quite a few residents and even attendings volunteer early on to join in this fight and join to volunteer their services for direct care. I was very impressed with that. I thought that was fantastic, and those volunteers were noted and Requests were also made by administration and other departments for people, and these people were utilized in various services, either directly or indirectly, to provide help for the crisis. The podiatry service needed to remain active and did remain active as we provide essential services, including treatment for things such as I have listed: sepsis, abscess, gas gangrene, CLI, OM trauma. These things didn't stop. There was limited clinics, which I'll discuss. They were suspended initially as far as the podiatry clinic and the podiatric peds clinic. Now, we generally have podiatry clinic on a daily basis, and sometimes we have 2 clinics per day. We have a pediatric clinic that meets once a week for podiatry. So those were suspended, and those patients that were necessary from those clinics to be seen were seen in our wound center. The wound center was actually moved to a different location for safety, and that was very beneficial to all of us. All the podiatry residents and all the residents in general were recalled from all their rotations to assist in the crisis. So this was for inside and outside rotations, which we have. In the wound center itself, as I mentioned, we moved the wound center. There was a building. The hospital operates several buildings outside the hospital, which are certified facilities for treating patients and providing other services. So there was a building that was being refitted for another purpose, and that was quickly refitted then for our wound center to keep those wound patients out of the hospital and in an environment that the patients, the staff, and everyone could safely operate. So that was fortunate. We had these brand new rooms available, and that we were able to move the service there. We were required to have limited patients initially. That was a mandate. And what we did is there was a great outreach by staff, by doctors, by residents to provide the telehealth, which is still ongoing, to assess patients either through telephone and or telehealth methods to make sure that they were being provided proper services, that if their clinic visits, which is difficult some to extend outward versus have them come in so immediately, that was done. This is, as you know, a very difficult process. We know our patients quite well. We know most of them at least, and what their needs are, but there are situations where you can't tell by a picture or patients relating things to you, or even a visiting nurse, what is exactly going on. So there is some risk involved, which we tried to mitigate. What we tried to attempt to do is get family and nursing services and other services at home involved as much as possible and informed as much as possible, not only to provide the wound care, but also regarding updates and education and safe and effective practices in what patients should and shouldn't do, and how they should quarantine or isolate if necessary, how they should come to the hospital and when they should come to the hospital. So this is an ongoing issue, but it's been quite successful. Resources and materials in the clinic is always a concern. We want to make sure that our patients are receiving all of their supplies that are necessary, all of their medications, all of their services. We don't want to have a loss in quality of care. We don't want to have patients' conditions get worse because of this crisis, and try to do everything possible. We tried to perform procedures that may have been OR procedures in the clinic or put them off. We are trying to limit, and we're trying to limit, especially early on, but even currently, hospitalizations and visits to the emergency room. Not that we don't always do this. We certainly want to do this, but in this crisis, even more so. And again, fear of the patients, and also our ethical and moral responsibility to try to keep these patients out of the hospital, especially in this crisis situation, and keep them safe. We want to modify yet make sure they're effective. That's, of course, important. Having these patients receive advanced wound care products for the purpose of superior wound care, and also time involved. Many of these products only need to be changed on a weekly basis. If they can't receive these products, they're not getting adequate care, especially if they don't have adequate home services. We utilize a lot of cyclical topical oxygen therapy, which has been highly beneficial and is a home available therapy. And we wanted to make sure that this therapy would continue to be available along with other therapies, and that we were able to get approval for new patients during this time, and that required some additional effort. So on the floors and in the ICU, there was certainly some differences, and this is, obviously notable but important. The levels of PPE and necessary, and the types of PPE, the types of gowns, the types of head or foot gear, masks, and things of that nature was an ongoing issue. At the beginning, they were few and far between and very early on, but fortunately the hospital responded quickly, and we were able to obtain not only appropriate PPE, but also instruction, and this has been obviously very helpful for keeping everyone safe. We don't want to forget and lose our focus on prevention and on acute issues. How much effort are we going to put into prevention is the question, given the crisis. How many residents do you want to send to a floor? How many attendings do you want to send to a floor to see both COVID and non-COVID patients? These are decisions that we had to make. These are decisions that we made not lightly. We would discuss and try to ascertain what was necessary for that individual patient, for that individual consult, to keep them safe, to use appropriate levels, but not overdo the exposure of others. There was also a great effort, and remains a great effort, of keeping non-COVID inpatients and non-COVID visitors to the hospital separate and safe. And this is very, very important, of course. Again, I mentioned OR versus bedside procedures, trying to limit the operating room because you're exposing additional staff to potential dangers and risks, and exposing patients as well. The follow-up care for patients, as we know, is always an issue, whether they receive appropriate materials, medications, and also services. In this particular case, obviously even more important and required much more diligence as far as follow-up is concerned, and additional telehealth. So this was something that we put a lot of effort into to make sure that we didn't have any problems, or at least limit them. The use of PO antibiotics versus PICC lines, that was debated. How necessary was it really to have? And there's quite a lot of research on this topic that showed that oftentimes PO antibiotics could be, in certain cases, just as effective as IV antibiotics. We tried to weigh out each case carefully and make sure we came out with the right decision for that individual patient. So the podiatry residents' work and training was effective during this process, I have to say. I mean, I could say that, being very true, and they continue to work very diligently, responsibly, courageously, and professionally. I'm very proud of how they responded to this crisis. I was very surprised. I didn't know how they would take it. I didn't know if there would be complaining or issues, but I'd say for the most part, it's been fantastic. Now, again, I mentioned earlier about testing and who's being tested. All of our residents were tested for antibody, and many have been tested for the PCR testing also, to see if they have it, or they even with or without symptoms, it's available for those who want to do it. As the policies continue to evolve, we continue to educate and spread the information so that no one is at a loss for treating themselves, their patients, their families with the most current information that we can find. The safety and of the staff, of my residents, of our attendings, and everyone involved is, of course, of the utmost concern. Now, fortunately for us, our clinics have reopened, and I'm talking about the general podiatry and the peds podiatry, and our wound care volume is also increasing. We're doing this at a very steady and slow pace, as is expected and important for patient safety and to follow the rules that were given to us. Patient distancing, of course, hygiene protocols for those exposed to people with the condition or potentially exposed. All of these questions are asked and answered, and procedures is really important when it comes to this. We're still awaiting that Tier 1 and Tier 2 approval, as I mentioned. As far as resident academic education, I have to say, now these lectures are sponsored by Presents, and I have to say that I believe that presents, not just because they're our sponsors, but because, or they're hosting this, that they responded quite well to this crisis, and they have provided our program, many residency programs, with many additional lectures. They've also provided the colleges, I believe 6 of them at least, with free lectures to educate their students who are need to do their education remotely, which is fantastic. So they should be commended for their efforts and their support in this regard. We've also utilized, there are many other lectures that have become available through either various societies or companies that are also excellent lectures, and that we've been utilizing. We're doing this nearly on a daily basis now when time permits, and certainly there's extra time when people don't need to travel to a meeting and they can do it through their computer. We've done the journal review, we've had longer and more frequent sessions as a result, and increased participation of our faculty. The reason for this is manifold. Number one, many of them have more time, but secondly, they don't need to travel. They can do this from home or office or wherever they are. So I've certainly encouraged them to participate and to continue to participate going forward on a more regular basis, as this is a great benefit both for them and for our residents, having them not only watch, but also give their input on lectures and on questions or posing questions that the residents may have, or answering questions that they may have. This is all very, very important stuff. And we hope this continues in the future. This, among many other things, are things that we want to use to our benefit in the future to make sure that we take a lesson from this and go forward with some positive ideas. We've also utilized these online quizzes, which are a lot of fun and challenging, and the residents and us have certainly enjoyed doing these quizzes on specific topics. We've reviewed chapters in podiatric textbooks, and we do this frequently anyway. We've had an increased review, so we've had an excellent academic situation. Now, CPME, the Council on Podiatric Medical Education, certainly there was a need for them to respond and assist in resident training and to discuss what they were going to do because of this loss of cases and training. And they issued a policy change for graduating residents, third-year residents, for lower MAVs, which is the volumes of certain procedures that are required to graduate from a residency program. There's 2 different segments of this. One is for RRA and one is for non-RRA or candidates, and there are different levels required. They did offer some relief in this area, and I think that was appropriate, and it was good that they came through with that to allay the fears of these residents for not being able to graduate. There were also rotations that were scheduled for the last few months that were unable to be performed and unable to be attended. And there is some relief in this area too offered. Fortunately for us, all of our graduating residents had surpassed all the required MAVs, and we were able to complete all their rotations. But this is perhaps going to be an issue going forward for some of the first and second year residents more than this for the third, because we don't know how this volume is going to return. We assume and hope that attendings will continue to support, that patients will return at equal levels, that there'll be a bounce back, and we assume it'll be equal and it will make up for it, especially during a 3-year program. The loss of a few months in numbers shouldn't be significant. But of course, we're concerned about this, and we're going to be monitoring it and doing everything possible to make sure that we have available and necessary procedures, numbers, and experiences for our residents. Now, I wanted to present a couple of cases for you just to show, some slight differences in things in our thinking and the way we manage these patients with the crisis at hand. This particular patient, the 71-year-old diabetic female, she was well known to us in clinic. She had a long history of PVD, of uncontrolled diabetes. Through her visits to our clinic and hospitalizations, unfortunately, she was educated and she became a very good patient. She understood the condition. She's optimized from a vascular standpoint. Her vascularity is not perfect, but She has regular visits. We watch and upkeep, and we visualize and discuss with vascular as necessary, and view all her labs and things like that to make sure she's in good general health and make sure she keeps her appointments. However, with the crisis at hand, she developed an ulcer, and out of fear, which many patients had, and out of being told to stay home, maybe a combination of both, I think in her case it was, she didn't come in for her appointment, even though she knew she should. She had an ulcer, and she had been told this in the past. Well, because she missed her appointment, she was followed up with a phone call, which eventually led me to have a telehealth visit with her. From what I could visualize, it looked like it was an infected ulcer. By the time she came in, she did have an abscess localized there with a grade 3 ulcer, plantar aspect of the heel. Normally, with a patient with this condition, we would admit this patient. A patient refused to be admitted, and we can understand why, but obviously there's risk involved, and we know that there's risk involved. We did do an IND and debridement there in the clinic on that day, and we did weekly debridements. We provided her with PO antibiotics, which were changed after, the empiric ones were changed after we received cultures. We did offloading, advanced wound care products, and she had used previously the cyclical topical oxygen, which helped her, even in comparison to her previous wounds where she hadn't. So we initiated this again for her. And fortunately, she was able to heal this ulcer in 6 weeks. Now, I do mention topical oxygen quite a bit because I think it's important. And it is why I mention it is because it's been a very successful treatment. And in this crisis, it's a home-based treatment that we can employ for very successful and superior treatment, I believe, and healing, which is shown by research for these wounds. In the corner, you see Freiberg et al. And other studies noted that show that these things mentioned are true. Is that the long history of use, the patient compliance is very high. The patients, it doesn't cause any pain if they don't have to carry the device around with them all day. It's useful with nearly all bandages, and you can modify certain materials that are impenetrable if you want to have them use this device without even having to remove the bandage, and it's non-contact. So I found this not only through research and my reading, but also through my personal experience, that this is really necessary for a lot of these patients and really helps them heal the wounds faster. So it's economically and also in almost every way, a superior way of treating many of these wounds if it's available. If you can find it, I would recommend it highly. This highlights some of the differences. I mentioned cyclical topical oxygen because I think this is a superior way of delivering it. Years ago, I also used other devices that I wasn't as impressed with, and this highlights two of them: the no pressure with continuous diffusion type device, the lower constant pressure device of 22 millimeters of mercury, as compared with the cyclical device, which gives you between 10 and 50 millibars of pressure. This creates a pressure gradient which helps reduce edema and also helps the oxygen perfuse better into the wounds. And this has been proven through study, and it works quite well clinically as well. So it's worked well for us, and even through research as well, it's been noted on diabetic and venous ulcers with a very, very low recurrence rate. And there are quite a few studies that support this treatment. It also can provide humidification when necessary, so you can have that moist healing environment that you might desire. So very recently, actually in March of this year, the print copy of this in Diabetes Care, this Dr. Freiberg, who's our moderator, this excellent article came out. This is a level 1 study, and as it says here, it's a multinational, multi-center, randomized, double-blinded, placebo-controlled trial. It's really a top-notch trial. You can't get better. As a matter of fact, it was even highlighted in the print copy with an editorial of positive support, one of 2 articles that was highlighted because of it's really a very excellent article and shows many of the things that I mentioned previously. This shows some of the results and that these results are verifiable. The P level is excellent, 0.004, showing that the study is quite reliable and a 4.5 times greater likelihood of healing these ulcers with the cyclical topical oxygen than with the sham group. Now, when I say the sham group, what I mean is they took a group of patients, and again, this was all randomized, double-blinded in every way, controlled study. And what they did is provided the device. The devices looked and worked exactly the same. No one knew who was getting oxygen, who wasn't. The only difference was that one device was programmed arbitrarily, 50% were, more or less. Some delivered oxygen and some delivered air only, so that it felt the same, it looked the same, and no one knew which were which. Well, the proof is in the pudding, as they say. In the final results in the 12-week period, 41.7% of those supplied with the cyclical oxygen healed versus 13.5 in the sham. That's 4.5 times greater. And in 12 months, 56% with the oxygen healed and only 20% without. So I think that's quite significant. And again, I found this to be true. This is another case I wanted to tell you about. This is a slightly different type of case, and again, presents some clinical challenges and even questions that, you know, we may have had different answers, but the way we decided to deal with it, given this crisis, I think, you know, to me was the best choice I could make. This is, again, a patient who had had previous ulcers and partial amputations of his foot. This particular individual had lost, you're going to see his x-rays shortly, you know, had several debridements. When he presented to me, he had bones and toes missing from his foot. He had open wounds and exposed bone. I was able to heal him pretty quickly. But of course, these present biomechanical, challenging, and also from vascular and wound care and diabetes perspectives and other perspectives, difficult cases that have, you know, recurrences in various different areas and different causes that are all related to those issues I mentioned. So this fifth met base ulcer, where he had already 2/3 of the fifth met amputated, was getting worse despite our attempts to treat him in clinic and keep him out of the hospital and keep him from surgery. So I decided finally that, listen, this was getting too bad. I was afraid of this thing spreading beyond the fifth met and into other areas of the foot, whether it be the fourth met or the cuboid or whatever it may be. And also that he would end up with some more permanent inversion deformity as a result of the loss of function of the peroneus brevis. So we finally decided to bring him to the operating room. I planned to do a debridement and possible peroneus brevis transfer, which I ended up doing. I debrided the tendon back, I think, to a very safe location where I could transfer it into the cuboid. I removed the entire fifth base to make sure that, you know, no more osteomyelitis. It wasn't noted to be anywhere else except in that fifth base would be present. And we did debate having a follow-up, and when the follow-up should be. We decided to have him come in 2 days just to make sure everything was okay. And I think, you know, we felt it was safer. We will continue giving him antibiotics, and we'll provide the cyclical topical oxygen therapy and advanced wound care products. We will try to do additional procedures if possible in the clinic. There's certainly a concern. We can debate this for long-term stability based on the loss that he has. You'll see his x-rays in a minute. I've done this procedure before where I removed the fifth met base and reattached the brevis, and it's not, you know, it's been done before, and I've done it before, and it's worked out well where it stabilized the foot. And I tried to keep the foot in you know, in an everted and dorsiflex position to try to put it in the stabilized, corrected position as much as possible. These are his pre and post x-rays. So as you can see, he had the only thing we did in this procedure was a debridement and the reattachment of the tendon and removal of the fifth. The other areas were not touched. They had been from previous procedures that were mainly done outside, except for some bone debridement that I did to heal his wound. Now, my final case is a common podiatric case. These cases are common where we have vascular and ischemia along with osteomyelitis ulcer. That's very common. This particular individual had an AKA already on the left, developed ischemia, acute ischemia in his right foot with osteomyelitis of the second toe and a kissing ulcer on the first toe. So we coordinated a telehealth visit. The vascular surgeon was a colleague of mine as well, of course. So we tried to make sure that everything was done in one visit when he had to come to the hospital in order to limit exposure and for safety, of course. So he had the non-invasive vascular studies, the exam, the pre-testing. The surgeon decided not to do the CT angio in this case to limit the patient's exposure and was able to judge clinically, although that's his normal practice. So that's a variation that he undertook as a result of the crisis. When the patient did come back for the ambulatory surgery, again, this whole amputation, partial amputation, was done on the same day, which necessarily isn't always done at the same time. But in this case, it was determined that it was important to do and limit the number of trips to the operating room. The proximal vasculature was addressed and visualized, and angioplasty of the SFA and the tibial were done, and a stent in the popliteal was done. Fortunately, with PO antibiotics, oxygen therapy, and wound care, this wound did heal. So this was another, interesting case to us. And these are the results of the SFA pre and post, and the PT pre and post that you can see provide better vascularization. So a question arises, at least in my mind, always, what's the loss in training? I mean, I'm a residency director. I have to consider this very strongly. So I've already reviewed with you that I don't think academically there's a big loss at all. As a matter of fact, it's been enhanced. So we kind of went through that already. I'm not going to rehash it. In podiatric training, yeah, there's a loss. There's a few months where it's been minimized. But again, the loss has been minimized as well. We've had ongoing clinics. We've had in hospital patients. We have our clinics now reopened, including our peds and our podiatry clinics. So this is a temporary loss as long as things return sort of to normal. In surgery too, there's been loss in some elective work and experience for our residents. But we've had the trauma and infection cases, and we've had the inpatients. So this my concern is going forward for first and second year residents. How significant is this going to be? How is the volume going to return? Is it going to be up to the same level? Is it going to be in some ways increased at some point? We can only, it's a conjecture. We don't know. We're going to find out. But it's a concern. It's something that we really can't close our eyes to. We have to monitor it. We started our outside rotations again yesterday at some of these outside hospitals. They're not in New York City. They're able to do elective surgery, and in our hospital very shortly, that's going to be happening too. I have to add this. This is something I feel very strongly about. What have the residents gained? And I think this is very important. It's interesting because I wrote this slide up, and as I was listening to the Department of Health, they had an expert from Michigan, Dr. Kroll, his name is, and he echoed many of the things that I have written here, and he thinks this is also very important to consider for all healthcare professionals. I was relating this to my residents in particular. Dealing with this crisis and managing patients and the roles they've taken, to some extent, stepping up to the plate and being asked to perform under these circumstances gives you a great sense of pride. It matures you. It makes you more cognizant of the teamwork. And I try to remind them of this and thank them for this and make sure they understand, which I know they do in many cases already, but it's my job to remind them of how important it is that they work together, that they're really doing something important, and I'm proud of them for what they're doing, and that they're important. Every day they come to work, they're doing an important job. They're helping people. They need to continue to help themselves, their families, their colleagues, and that they're truly serving as role models for our society. This has been well recognized. It's a nice thing to see for me, and I think for many of us as healthcare providers, that the national recognition we're getting, not just to be patted on the back, but people understand, and it makes you feel good that you're appreciated in this world, that you're doing what is morally and ethically needed, and that people see and appreciate it. That makes it really worthwhile. I think as a result, the residents will gain for their future. This is something that may have some very permanent positive effects on them as far as their self-worth, their feeling about themselves, their confidence, their value as a doctor and as a member of the community and healthcare system. Now, there's certainly been some negative effects. I mean, the residents have undergone a lot of stress, emotional, mental, not just the residents, but everybody. And there are counseling services provided both by the hospital, state, and other agencies. And we make sure that we help each other, that we inform them of what they need and what, how to get these services and kind of keep an eye on everybody. Unfortunately, the residents themselves, some of them have been affected and infected with the conditions of the attendings as well. Fortunately, they recovered. But some of their family, some of our patients, some of the patient's family, some of our friends and some colleagues and staff members at the hospital have passed away from this condition, and we witnessed it, and we know these people. And that's very, very sad. And I really feel for the loss, for sure, as we all do. So what have we learned? Well, this is part of this is my belief, and part of this I think is just common sense. I believe that we should consider some form of additional modified social distancing, PPE, and certainly, hopefully, people would adhere to the advanced hygiene and hand washing that's been around for many years. More so now that we've seen what can happen. Infectious disease is a reality of life. It's always been, and even more minor conditions do spread and cause death and cause really serious illness to many of our elderly, to those who are who are children and those with a lot of comorbidities. I believe that we should consider this more and more seriously now going forward, not as a reactionary idea, not as something where we're going to overreact, but something that's logical that we need to consider when we have both outbreaks, but also in prevention for things like flu season and things of that nature. It's not so terrible to have to wear a mask sometimes or distance yourself sometimes. It's smart sometimes. So we don't know what future policy will dictate. We don't know if there's going to be any enforcement. There certainly seems to be very little at this point, as far as, for those who aren't following, mask wearing and things of that nature, at least in my community. We don't know what public and private industry response will be. I think there's going to be some, and I think that's a good thing. And I would support that because we want to keep people safe. The other thing I would say is that we certainly are going to expect that as time goes by, there's going to be a lessening of fear and lessening concern for health risks. This is human nature, but that we should not lose complete sight of what's logical and appropriate for preventing issues and minimizing the effects of infectious disease going forward. As far as the wound care in the hospital itself, and this is, I think, nationwide, perhaps worldwide, we see how wonderful telehealth can be. It's not everything. You need to see patients in person sometimes, and quite often. But we hope, and I hope, that the insurance industry and regulating agencies see that telehealth should be covered fully and well, paid for properly, so that it minimizes the difficulties for us as healthcare practitioners and for patients and family. Virtual communication is wonderful, and for patients to have to travel back and forth sometimes for minimal issues, the cost, the comfort, especially those with many appointments or serious acute and chronic conditions, it would be very helpful if this would continue and be covered as a service and be more employed. As far as doing procedures in clinic versus inpatient, trying to keep patients that this has been an ongoing effort, but I think this puts, even more emphasis on that. Again, I mentioned this again, the enhanced PPE and infection control policies. I think that's very, very important. So as far as residents and stewards going forward for this particular year, this Coalition for Physician Accountability came out with what they call its final report. Now, this is an association that includes, among others, these organizations that are listed. So what they came up with for national residents and students is that they're discouraging and limiting away rotations unless they're absolutely necessary for training, and trying to keep them geographically close or proximate for at least this academic year. And I think that was an appropriate response. And as a response to that, what we've done for podiatry, we canceled our clerkships, our externs for the year for now. It's canceled until further notice. We're going to hold our interviews as we've done before through a virtual platform versus in person. We're going to have the continuation of the lectures virtually, with hopefully participation of faculty to be included. In addition, our orientation sessions, not just for podiatry, but for all of our residents and incoming students, are going to be done virtually. I'm sorry, not students, we're not having students, but for our residents. We're trying to keep a limit on in-person meetings, which I think is great for many reasons, for safety, and also it's easing your burden of having to be at a certain location. I found this to be wonderful, and I can participate a lot more thoroughly and easily by doing virtual meetings, and I hope this continues. I do want to emphasize as a last point that there is a great need for, in not only in our profession, but in many fields, hands-on training, so that we need to utilize that where it's necessary and not allow inferior training to take over because of a fear of only using virtual training. We have to be sensible about these things. So I think that's an ongoing thought, and it's something that will enter our minds, and we'll respond to it appropriately, I'm sure. So with that in mind, I want to make sure that you get your CME credits and also that I answer your questions. I'm looking forward to some questions and anything that you may be concerned about or interested in. I thank you for paying attention and watching this lecture, and I hope you enjoyed it. As far as the CME is concerned, if you logged into the webinar, you will receive a survey. You must complete this survey, which will be emailed to you later in order to get this credit. And then the certificates will be mailed out a week later. Thank you very much.
Well, thanks, Ron. That was really a very informative lecture, and I think we all appreciated it very much. And I'm happy to say we did generate, or you did generate, a number of good questions. But let me start off our discussion by asking you to summarize things that I think you pointed out very, very accurately. Do you see a new paradigm for podiatry residency or residency education in general, and how so?
Well, I think that I alluded to some of the things, but I'll try to cover it succinctly. I think the new paradigm will include more virtual education, no question. That's the number one thing. I think other parts of the training, anything that can be done, any meetings that can be done, and this is not just for podiatry, from a virtual standpoint, we'll try to do that. You know, we want to keep people safe, at least in the coming months, and there's an expected spike again or recurrence in the fall, so we have to be vigilant until that time. Following that time, then I think we have to reassess. So for now, I think we're going to continue with this policy going forward until we see that this thing continues to wane, and also if there's a spike. After that, then that's the time that we would reassess. As far as requirements of procedures, that's up to CPME. I don't think that they should necessarily water it down. I think it should be okay. But if for this year there is a decrease in volume, I think that they should allow for that for some of the current residents, and then return to normal following that. But we'll have to see if that's even necessary.
You also mentioned some of the positive attributes or aspects of this crisis for your residents. And looking at a larger overview, do you think that you can embrace some of these positive experiences and incorporate them into your overall training program as we move forward?
Yeah, I think it's important, and I think it's going to be a story to tell that I'm not going to forget, because I think sometimes residents, you know, people in podiatry sometimes, or residents in general, doctors in general, there's a lot of sort of the feeling that you're not that important. You're, a big deal. I became a doctor. So what? It sort of lingers in certain people, the lack of appreciation for what they've done and what they've gotten. And I'm always cognizant of reminding of them of how important. But this particular story, I think, will really resonate for a long time in saying you guys are really important. And I will cite you examples of what was done here and what I witnessed. And this is not just because of the crisis. This is the job you do. These are the patients you care for regularly. And your service could not be wiped out. Your service was essential and needed to continue. That should tell you something about who you are and what you are, and give you a sense of the leadership you need to have, the ethics and morals you need to have, the feeling for continued education and best practices that you should have. And I think all of that going forward is going to be a very positive influence on residents and on doctors going forward. The fact that we've been so well recognized nationally, I think, as healthcare providers, I think we've been beaten down a little bit over the last couple of decades, and I think maybe that recognition really means something to us. It does to me, and I think that gives us a good feeling going forward.
Okay, very good points you've made. Let's go through several of the questions. I don't think I'm going to be able to get through them all, and I'm very happy that we have a number of them. But our first one is really relating to how do we handle all of our patients, some positive, some negative. Should we just manage all the patients as though they're COVID positive? And I think you alluded to that too, with the need for PPE all the time and testing. But what is your approach? Is everybody positive until proven otherwise?
Yes, I mean, we have to use all of the protocols for ensuring that potentially that patient, even if they were tested and were negative, a couple of days before, maybe they had an exposure. Maybe they're not being completely honest. Maybe they're not aware of the fact that they could have gotten exposed or had the condition. There could be all those things in play. So yes, in our hospital, as I'm sure is true in almost every healthcare institution and office, there's questionnaires, there's questions that are asked, there's temperature testing, there's patient testing, but this is not a foolproof system. So you have to assume that anybody could be positive and not let your guard down. We see a lot, patients come in, they have their masks on, and they often let the mask slip down into their nose, under their mouth. This is not acceptable. And I'm not a really harsh person when it comes to disciplining patients in that manner. But in this particular case, I have to say, listen, you really have to put your mask on properly. You really can't be standing over here. You really can't be walking over there. You have to be vigilant, because the health of many individuals is relevant to the behavior of these individuals, and also for their own protection. So, yeah, yes, you do have to assume in a way that everybody has it, and that's the best method, and not let your guard down.
Great. Here's a really relevant question. Are you or any of your colleagues involved in any clinical trials? Really important problem. And how are study visits modified as a result of the pandemic? Big problem for those of us involved in clinical trials.
We are not currently involved in a clinical trial, so I'm not, that's not relevant to me right now. So I don't, there's nothing really more for me to say about that, but you could probably, you might want to answer that question.
Yeah, and you addressed much of this, although we recognize that the impact that this would have on in-person visits, but this is where telehealth would really rise to the occasion, I guess, because most often digital imaging is done. It can be done remotely. Home health care can evaluate patients. Even providers can go to patients' home. And I think that's part of home care as well. So it's been impactful. I think we'll learn more about this in the future. As you mentioned, many of your clinics were not ceased entirely, and some of them could be held on a limited basis. So this would be an interesting thing to explore in the future. How did research trials fare during all this pandemic? I don't think many of them absolutely shut down, but they were slowed down, to be sure. But thank you for that good question. Another question, in terms of telehealth and distance-based care, do you or any of your colleagues utilize home health services for wound dressing changes and assessments? If not, would you see this as an effective tool? I think you addressed that.
Yes. I did mention a couple of times about the visiting nurse services and trying to coordinate. Now, there were initially both reports and also a reality of a loss in some visiting nurse services. Some of the nurses, again, with either fear or risk, they themselves may have had comorbidities. They couldn't perform their duties. They weren't able to perform their duties as visiting nurses. So there was a loss in the number of visiting nurses, and that presented a challenge. That's why we kept in much more close contact, I would say, with the visiting nurses during this crisis. And in addition, tried to assess both using the visiting nurse and also discussing with the patient through telehealth whether or not family could offer additional services, that particular nurse could offer additional services, and or was it appropriate, and getting that nurse, visiting nurse, to help us make some of the assessments by positioning the patient or asking them to palpate something or turning the patient in a certain way. There were many discussions that occurred that were very helpful, and having the visiting nurses there was extremely useful and necessary to provide the right answers, whether that patient was being cared for, whether the change was necessary. Some of these nurses really know their patients, and they see whether they're doing better or worse, the ones that are really involved, and they can clue you in as to what's needed for that patient.
What sorts of telehealth tools were you using? Any particular program? I presume the digital imaging or even real-time imaging was used, since we all have cell phones.
Right. Now, the hospital itself uses doxy.me for their direct inpatient or clinic patient services. That's what they signed up for. But they okayed, and we had many discussions about this, whether people wanted to use Doximity or other platforms, whatever was appropriate or necessary to use, whether it was through your cell phone. When you were in the hospital, you were encouraged to use the doxy.me because that was what they had wanted us to do. But we were able to use other platforms as long as they were legitimate platforms, and whatever means was necessary to communicate was approved by our administration. So we used a variety of things, and I did as well. And being in my car, and getting a phone call sometimes, and then pulling over, and I would use whatever means I could use, whether it was Zoom, whether it was WebEx. These were all considered to be okay. I had heard things about, security issues, but these were approved by New York State Department of Health to be used, and by many of the insurance companies, so I felt it was satisfactory.
So there's been a relaxation of many of the rules so that we can handle these patients. That's appropriate as well. Okay, here's another question that you more or less addressed, but perhaps you can address it once again. Were the residents able to participate in care of patients beyond the scope of their typical training?
As a matter of fact, they were under and there was a special mandate that was put forth by the state, by the governor, and by the Department of Health in New York that allowed for this type of thing specifically to occur. This was done, and hospital regulation often, they must follow mandates and recommendations, of course, but they may sometimes have more stringent, as we know, policies. So sometimes, even though it might be allowed, the hospital might say, that's all well and good, but we're not allowing it. But in this case, the hospital did allow for it. And what they did is they had the residents working under a variety of different departments, all the med surg departments, and they would under direct supervision of qualified people in those areas, and were able to perform and did perform tests and things on patients to their ability, and with guidance and assistance on patients outside their scope of practice.
Here's another question, I think very relevant, related to this one. Several years ago, I started having our residents do a formal ICU rotation. Not that they normally come into practice, but they need to be aware of procedures and methods used in the ICU. And so one of the questions was, were any of the patient residents involved in ICU care of COVID-19 patients? Were they detailed to the ICU to assist in the care of these patients?
Yes, they were. We have also had an ICU rotation, and but this particular time, there were a good number of patients obviously in the ICU, and the ICUs were very full and even expanded. And yes, we had resident participation in those areas as well.
Okay. Did any of your staff or residents actually become ill from the virus? You said that several tested positive. My question relates to the manifestation of illness directly related to the viral infection.
Yes, they did, and several of them had to be out for the required period of time, and some were then some were tested, some were not, some went by symptoms alone, and then by especially early on when testing wasn't available as much, they were able to return after 72 hours of being without symptoms, without fever, and so that was the protocol. Whatever the protocol that existed at that time was followed, and quite a few of them did, and quite a few of the attendings also had the condition. Exposure for us, if you're using proper PPE, and even by the numbers, for healthcare workers, even in Brooklyn and Queens, New York City, the rates are actually lower than the state averages. I think because healthcare people are more aware of how to act and what to do. But certainly early on in the condition, in the crisis, quite a few people, quite a number of them did get the condition and were required to be out of work and stay home.
Well, the 14-day quarantine period is so common now. Did it evolve into cases where if you tested positive for the virus, were you required to be placed at home for 14 days, just in case you exhibited symptoms?
Yes. If you had symptoms of any kind, whether you were positive or not, you had to be home for 14 days.
So a significant impact on your staffing
Yes.
to handle all the care that was required.
And then after the 14, you had to have 3 full days of being clear of any type of symptoms of fever.
Okay, great.
14.
Great, that addresses another question. Let me ask you this, and this is in reference to some of our other questions. We're now practicing, as you mentioned, so-called wound center without walls, based on a recent paper by my friend Lee Rogers, who also trained there in New York City. And you were mentioning the new technology that you did mention that we published a recent paper on topical oxygen. Do you think that made a very positive impact on your ability to successfully heal these patients, since you were not able to see them on a regular basis in your clinic, by using a home-based therapy such as the cyclical topical oxygen? Did it make a positive impact on your ability to handle and care for these patients?
Yeah, it really did. I mean, I think I sort of outlined that in some of the cases too. But the fact that we were able to provide this at home and know that they're receiving really advanced best practice treatment for their wounds that would help them heal faster, and that they could do this from home, was very reassuring to us. And we certainly saw healing that occurred quite well, as we've seen with the device in general. And as I mentioned, we were able to get approval for even new devices and make sure, through the company reps, through the insurance industry and coordination between me and the reps, that we were able to maintain supplies and the treatment of the condition using the cyclical topical oxygen at home. I found it to be excellent. I found the wound healing rates to be superior, as is mentioned in your research and other research. And it was very important to me that they not lose that, because it's a home therapy. It was perfect for this kind of thing. And it was very reassuring that it was available and it was able to be continued.
Okay, thanks, Ron. Unfortunately, we've reached our hour benchmark here. We have a lot of great questions. I want to thank you, of course, and everyone else for participating in this. And I do want to mention and address several of the questions about the presentation. Should be available on the Present website. For your CME certificates, they will be emailed to you once you do the required survey, as indicated on this slide that we're all viewing here. So we appreciate you all for your attendance here, your active participation. It's always great to see a vibrant discussion period. I'm sure you appreciated that also, Ron. And
yes, very much so.
I want to thank you for your insightful presentation, a very timely one, of course, from the center of the storm, as I guess we can call it. And it looks like you and your program has survived well, and probably with positive changes coming out of this for the future. So with that, I think it's time for us to bid you farewell. Thank you once again, and we hope to see you all at the next Present webinar. Thank you. Thanks again. Goodbye, everybody.